When interviewing H, I was faced with a man who had lived through the kind of adversity I could only imagine. He's a friendly man with a calming, grandfatherly manner that took me aback as he discussed discrimination, segregation, and the threat that racism posed to his safety in a tone that made it evident he long ago accepted this as his normal. Quote, "When I was a little kid starting off, there was only like 1 or 2 doctors that everybody in the whole West Side would go see. So you would go to the doctor's office, there would be 20 people, 30 people sitting in the office, and of course, all black, waiting there for the one black doctor that there is in the whole community. And half the time you're sitting there, you're there for about 2 hours and haven't seen him come out and get anybody for a while, and discover he's gone for coffee. We got a lot of that, every time. Sometimes you'd have to go back 2 or 3 times to see a doctor because that one doctor would take off and go play golf in the afternoon." End quote. In a moment, it's easy to point the finger at the doctor here and say, hey, shouldn't you work until the work is done? But when you really think about it, that's not really fair. These comments get at something much deeper and darker than a physician's work ethic. Here we can really see the underbelly of the flawed ways medicine is structured, not only in a way that is harmful to patients, but harmful to doctors as well. In talking to doctors for this project, we discussed the distribution of providers in the country. To say the least, it isn't even. Rural communities and low-income urban communities rarely have enough healthcare workforce for their population. One of the reasons why is financial, and this is more complicated than it sounds. To put it in the politest terms possible, medical education is expensive. If you've ever seen the movie Coraline, they describe a secret well as being so deep if you fell to the bottom and looked up, you'd see a sky full of stars in the middle of the day, which at this point sounds like the perfect metaphor for the amount of debt that I'm in. Altruistic intentions can only get you so far, and while a great many people go to medical school wanting to help people, to make a difference, to go where the need is greatest, 4 years and between $100,000 and $400,000 later, some practical decisions have to be made. The average age of people starting medical school class at CU in 2015 was 24 years old, which is actually young compared to the national averages. Most of the time, students graduate in 4 years. I'm taking 5 years because I also decided to get my master's degree, but it can take up to 9 years for those that get a PhD in addition to their MD. People in their mid to late 20s also tend to be getting married and starting families. The truth is that many times private hospitals and clinics in more specialized fields just pay better. Even discounting that sometimes people who want to help just aren't a good fit for the most helpful specialties, I for one don't have the attention span for internal medicine. Sometimes doctors must make the choice to take care of themselves first. While a coffee break may inconvenience patients when you're the only physician working in a clinic, if you're the only one seeing 30 to 50 patients a day, every day, you need something to keep yourself sane. We're beginning to touch on another subject, physician burnout. If this is your life, day in and day out, your debt is piling up, you've got kids depending on you whose lives you're missing out on because you're so busy, how much would it take for you to say, it's just not worth it? Medicine isn't an easy field. I'm not even graduated, and I've had to have conversations with parents about what kind of hospice care they want their child to have. If most people saw the aftermath of a small child being an unrestrained passenger in a rollover car accident, it would be traumatizing. For some doctors, that's Tuesday. I'm not trying to defend doctors who seemingly throw the most needy populations under the proverbial bus, yet it's critical to understand the precarious balance doctors maintain and the requirement for a firm sense of personal limits. None of this gets around the fact that the ones who draw the short stick here and pay the highest price for this brutal structure will always be the patient. And this is institutionalized racism. The structure of the medical system is to devote as few resources as possible where the need is highest and insurance coverage is lowest. Are politicians, hospital administrators, and doctors aware that this puts disproportionate strain on people of color and immigrant populations? Yes. Can your average family medicine provider do much to help fix that by themselves? No. H also talked about selection of medication. He describes feeling left out of the decision-making process. He knows other medications exist, but he struggles to get his doctor engaged in discussing this with him. Quote, "The doctor is just going to give you the quickest thing, something that's been out there for quite a while, nothing I feel is exceptional or different or more expensive because they feel you can't afford it." And the truth is, he's not wrong. Talking to physicians, they raise the issue of whether it's unethical to present options that you know your patient can't afford. It isn't unusual for medications to be in excess of $1,000 or more depending on the disease. Is it really right to tell patients about this medication that can treat their disease more effectively, but would cost more than their monthly budget to take. Personally, I'm of the opinion that people are the best gauge of what they're willing to pay. Some out there would disagree, but my opinion on this matter mostly stems from stories like H's. Quote, "Even if you are well-educated and intelligent person, they just assume you can't afford it. I'm working a decent job, I'm educated, I understand what's going on. They have these preconceived ideas about what Black people or minorities are going to do. You're not going to take the medication, you're not going to follow up on it. Maybe you will take it one time, but you won't refill the prescription or anything like that. And it just gets very frustrating." End quote. We've already been over it. Doctors are people. They are going to have biases. If their bias, subconscious or otherwise, is to believe that all Black or Hispanic people are poor, they may not get to know them well enough to know that they have good insurance and a high-paying job. The doctor's judgment on what someone else can afford is always going to be flawed unless they have known the patient very well for a very long time. And should it ever be someone else's estimation of what you can afford that decides what options that you're told about? There isn't anything else where this is the case. I mean, the last time I bought a car, I certainly couldn't afford a Tesla, but I still knew that they existed. Cost is a factor in deciding what the right option is for yourself. What does insurance cover? What is the side effect profile? How hard is the drug to take? And still the elephant in the room, are there other options that would work better for me? Yet on the same token, one needs to consider the depth of these medical questions. Is the best drug for your problem a drug? What if you can get better control of your blood pressure and diabetes by changing your lifestyle? How much weight would you need to lose to gain control over your diabetes? And then you even get questions like, does an angiotensin-converting enzyme inhibitor work better than an angiotensin II receptor blocker? Patients are going to their doctor for their expertise because they have between 8 and 15 years of post-high school education on these topics. Your average person's understanding of nutrition might only extend as far as the latest fad diet. And I've talked to many patients who don't know the name of their medications or what they're supposed to treat. Realistically, it's not the patient's job to understand the difference between clonidine and clonazepam. Some medical school classes are about learning how to pronounce names like metoprolol. How much of an educated decision can somebody really make when, frankly, they don't have the education? As H continued, he said, "There's more to it than my arm hurts. But why? What have you been doing to make your arm hurt? Did you do something?" But they've got to sit down and talk with them. Nowadays, it's numbers. You got to rush them in and rush them out. That's what insurance will dictate, end quote. This is an important point. What doctors can do in a clinical setting is limited. Part of medicine is the numbers game. How many patients must be seen by each doctor in a given day for the clinic to be economically viable? If it works out to 5, then your doctor is probably going to be able to devote a lot more time to just you. If it works out to 30, you'll probably be lucky to get 20 minutes. Talking to doctors, they say it really shouldn't be that strange that you should come back multiple times to take care of an issue. If they only get 20 minutes to get to know you, your entire medical history, all of your medications, your primary concern at this time, how long has it been going on, and discuss all the options and what will work best for your lifestyle, you can see how this is a bit of a lofty expectation. Now, this is a huge problem in low-income patients who don't have the time or resources to devote to making multiple trips. Again, the medical system isn't well structured to help people like this, and a lot of folks end up not managing their chronic conditions well because of this reason. Is there a way to fix this? I can't honestly say. This is one of those places you truly have to face how much of a broken system medicine can be. Still, a different misconception that came out of this discussion was that if you're prescribed a drug that has been on the market for decades over a new drug that you're getting shortchanged, and this isn't necessarily the case. For example, metformin is one of the oldest medications available for the treatment of type 2 diabetes, and it's still first line for the treatment of type 2 diabetes, and that's because it works. If someone strains their back or runs a fever, are they going to Google the newest discovery of anti-inflammatories, or are they going to reach for a trusty bottle of ibuprofen? Old doesn't mean bad. In a lot of cases, old means proven. A factor that came out strongly in talking to Age was how many problems in medicine come from a lack of communication. Patients not feeling comfortable being upfront with what is reasonable for them, and doctors making decisions without explaining their logic. As H concluded, quote, "I'm not angry at doctors. I've just lost a lot of trust in doctors," end quote. As poorly designed as the current medical system is, how much frustration could be spared by just speaking more openly? Statements like, "I chose this drug for you because," could go a long way in reassuring patients. And from the patient's end, statements like, I am concerned about this drug because, can really help a doctor know where they haven't explained themselves clearly. The overhaul of the way healthcare is structured needs to happen, but as it is, it can function much more smoothly. With good communication, better care is possible. While the causes and issues in racism in healthcare are impossibly complex, the steps patients can take to get better care are simple. Ask questions, demand answers. If something isn't going to work, never be afraid to say so and explain why. If you aren't being listened to, say it louder. And if that doesn't work, find a new provider. Your health is on the line, and you have a right to have a doctor that understands that.